So it's time, so let's start. First of all, welcome everybody, and a special welcome to our speakers over here, like Gerry McElvaney, Laura Boonbreek, Jenny Shokes. I didn't see Jenny, by the way. Jenny, are you there?
Frans, this is Tiara. Jenny's going to join a bit later.
Okay, that's fine. She's almost at the end, so that's fine. Thank you. Yeah.
Thank you.
And Reino Doeschot and myself. What we're going to discuss today is basically about the MZ population, right? There are about 35 million of those individuals worldwide. And this group has actually long been misunderstood and really overlooked. Yeah. But if you look at the research over the last 5 to 7 years, right, especially data out of the UK Biobank, right, we see that there is a lot of stuff going on with the MZ population, right, both liver and lung, right, and that made us actually diving deeper into the research and forming actually this foundation to go over that. So what we will do in this presentation, we will share the newest research with you, right? The finding the morbidities and the biomarkers within the UK Biobank, and also the underlying mechanics of these conditions together with the solutions. That's why we call it from science to solutions. Let's go over the agenda. Let me see if I can click this to the next page. Yeah. I will do a short introduction. Then Professor Gerry McElvaney will talk about lung diseases in the MZ population. That's with the research, if I'm not mistaken, over the last year. I will talk about liver-related morbidities and the mechanics behind that. Then Laura will talk about an overview about intrahepatic cholestasis of pregnancy, which is very common within the MZ population. Reinhard will do a very deep dive within the DNA. So the Alpha-1 DNA explained, is called it. And that is really revelating, at least for me, that the DNA is working like this. Then we'll do solutions, we're going into the solutions, so the emerging medications and the therapies behind it. And we also have as the last one over here, BioMarin. This is doing a program overview of the clinical studies and the molecule as a solution for the MZ population. And we invited BioMarin because they're currently the only pharmaceutical company which is addressing also the MZs. And then we go into the closing remarks and the Q&A. So if you have questions, right, there is a button at the bottom of your screen. This is called the chat button. If you press that, a chat box will open. And then you can actually type in your questions. And Fiona and Nienke will pick up those questions, and then we'll ask the questions to the respectively persons which can answer that questions. So let's go into that. First of all, a little bit of a background of the MZ Foundation and how we started. We started officially in Q2 2024, but actually in Q3, Q4 2023, we were already busy with it, but officially we started over there in 2024 with a mission to really advance the understanding of the alpha-1 antitrypsin deficiency among MZ patients. There are 35 million worldwide with actually with an heritage of European heritage, I have to say. And we also like to bring that for patients and also medical professionals on a global basis. So we're not locally located. If you see our team later on, we're coming all over the world, right? And we're actually servicing everybody all around the world. We're conducting studies on the morbidities and the biomarkers with an emphasis on the liver-related outcomes because that's where the source of most of the issues are. Expanding our patient database to get more clinical insight and also to support statistical analysis and the disease burden, of course, but also the economic impact. You can imagine that with an MZ population of 35 million persons, the economic impact of this disease is also quite high. We published our findings actually in a weekly newsletter and on our website. The weekly newsletter is quite well read. This is done by Nienke. And I believe, Nienke, that in the first, let's say 24 hours, I believe 95% has opened the email and read the email. So it's a very clear path to provide actually all the information to our followers. Yeah. And what we're doing there is we're doing our research publications on medical research, clinical cases, clinical data, also out of the Alpha1 MZ community. So the Facebook group we're seeing is also quite important to us because from the Facebook group we learn what is going on within the Alpha1 MZ population and what issues there are. We're completely independent. We are really dedicated to scientific transparency. So we have completely open access. Everybody can use our findings. Everybody can do whatever they want with it, right? We are in full collaboration with medical and academic persons and regulatory institutions. The team, really a cross-functional and international team. We have myself, founder and researcher. I have a technical background, a research technical background. Nienke, by the way, I'm an MZ. Nienke is an M-Proxida Z. She is responsible for the financials, the website, and the communication part. Kristen Hatcher is recently added. She's going to do the registry and the data collection. Margaret Miller, a lot of people know her already. She's a patient advocate, I think, for 20 years, right? Reinoud Doeschot. Reinoud is our secretary, but also researcher, and he is coming out of the healthcare system of the Netherlands, so he knows all the insights out with the EMA, etc. Then we have Dr. Fiona Palmer, which has a very strong background in bioinformatics, pharmaceutical, but also computer science. So it's a very broad range as well, and she's teaching at the university. Then we have Dr. Laura Boonbreek, researcher in gynecology and also part of the ICP group in the United States. On the background, we have Ulrike van der Stelt as medical advisor, but we have more medical advisors. We have, for instance, also Professor David Alpers out of St. Louis, which is in the background and is what I always call keeping us honest in terms of research. Yeah? So that's the team. Quite international. I believe Margaret is in Canada, Kristen is in the United States, Nick is in the Netherlands, Fiona is in Northern Ireland, and Laura is in the United States again. So we are all over the place. Now the word actually to Gerry. Gerry, if you can share your screen, then I will stop sharing mine here.
Thank you very much. I will start sharing now.
1 second, 1 second. I have to get my cursor down and stop share. There you are. Yeah, go ahead.
Thank you very much. Can you all see that?
Yes, we can see it now.
Great. Let's see now. Okay, so I'm going to talk about MZ Alpha1 antitrypsin deficiency status, and I concentrate mainly on the lung disease associated with Alpha1 and touch briefly on some other areas as well.
Good.
But here's the classic graph you're all familiar with, Alpha1 antitrypsin levels versus phenotype. And you can see that a ZZ individual has a level of around 5 micromoles, SC individual around 11, and MZ and SS approximately the same. And then we have MMs and MSs. And for many years, it was thought that people below this 11 micromolar threshold were at increased risk for lung disease, and people above that level had no increased risk. Now, we don't believe that, but that was the generalized dogma up until relatively recently. The risk was thought to be increasing according to the lower your level. Lower levels, higher risk. So do MZs have an increased risk for COPD? That's the big question.
Yeah.
Now let's talk about COPD first. COPD is characterized by airflow obstruction that is not fully reversible. That is the definition. It's usually progressive and is associated with an enhanced inflammatory response to noxious particles and gases, primarily tobacco smoke, but also pollutants in the air as well. It's a heterogeneous condition. It's characterized by two main phenotypes, chronic bronchitis and emphysema. In chronic bronchitis, Generally, people have a cough productive of sputum most days for at least 3 months for 2 consecutive years. And this is because there's mucus hypersecretion. So that's chronic bronchitis. Emphysema is classically defined by abnormal and permanent enlargement of the airways distal to the terminal bronchiole, with destruction of the alveolar spaces and capillary bed, leading to a decreased ability to oxygenate blood. So your classic person with emphysema is like the gentleman on the left here. He's got what we call a tripod position. He's trying to breathe as well as he can, but he's using accessory muscles of respiration. You can see his rib cage is quite easily seen here. He's having to use accessory muscles to get the air in and out of his lungs. Now, up until recently, up until the last 30 years or so, this diagnosis was difficult to make without an autopsy. But with the advent of CT scans, we can make the diagnosis of emphysema quite easily. And you can see the CT scan there on the right, and that shows what we call bullous emphysema. See those black areas? Those are parts of the lung that are no longer able to engage in gas exchange. So you can't get oxygen from the air into the bloodstream in these areas. So how do you diagnose COPD? Well, a classic thing we do, and a lot of patients here will be familiar with, is spirometry. The amount of air you can blow out. So in COPD, the amount of air you can blow out in 1 second is reduced compared to the amount of air you can blow out overall. So let's look at the graph on the top right-hand corner. It's volume versus time. And as you can see, most people can blow out almost all the air out of their lungs in the first second. In people with COPD, and this is what we get with severe alpha-1 antitrypsin deficiency, the ratio of FEV1 to FVC is reduced. In other words, the amount of air you blow out in 1 second is markedly reduced compared to the amount of air you blow out overall. Flow is also decreased at low lung volumes, what we call the FEF 2575. So you'll see a lot of people talking about this during your pulmonary function testing. They talk about your FEV1. They compare your FEV1 to people the same age, height, and sex as yourself and give you a percentage. They look at the ratio of your FEV1 to your forced vital capacity, the FEV1 over FVC, and that'll be reduced in COPD. And they'll also look at your FEF 2575, the flow at low lung volumes. All these are reduced in people with COPD. You'll hear of another test we do called diffusion capacity, DLCO. That is also significantly reduced in the setting of emphysema. So you diagnose COPD by talking to the patient, taking a history, examining the patient, but you do pulmonary function tests. If you don't do pulmonary function tests, you cannot make the diagnosis. So there have been a lot of studies to see whether MZs are at risk for lung disease. And this is probably the best of them. This is a study by Craig Hirsch, published years ago in Thorax. And he looked at a number of cross-sectional studies which compared the mean FEV1 percent predicted in MM and MZ individuals. And they found no difference in mean FEV1 between PI, MM, and MZ individuals. And that was quite interesting. Part of the problem here is that in many cases they would show that in a COPD population there seemed to be increased numbers of MZs, but the lung function in these populations was no difference between the MZs and the MMs. That was the problem. And this was mainly due to what we call referral bias. People were only tested for alpha-1 antitrypsin deficiency if they had COPD. So therefore, a lot of people with MZ alpha-1 had COPD. So this referral bias made it very difficult to determine whether MZs had an increased risk for lung disease. The next big studies were by Sorheim et al. And these are two large population studies from Norway and Europe and the US. A multi-center family-based study from the US and Europe, and the big study from Norway. And what they showed was that MZs had lower FEV1 FVC ratios in both studies. So that was the first inkling that people with the MZ form of alpha-1 had obstructive lung disease. They also had more emphysema on CT scans. So then other data began to emerge. This is a study by Searsom et al. Now he used the Danish registry. The Danish registry is really, really good. What they did was they derived 10 matched controls for each MZ identified from the Danish Central Population Registry. And then they looked at discharge from hospital. Of 1,551 MZs, 47 were identified as discharge diagnosis from hospital of obstructive lung disease. So 47. 206 with this disease in the control group. So in the population, the general population, 206 versus 47. And remember, this is 10 match controlled for each MZ. You would have expected far more in the general population. This difference was only found in age groups between 40 and 79. And of the MZs, 36% had first-degree relatives who were ZZs and were symptomatic. So it seemed to be if you're a symptomatic ZZ, your MZ relatives would be more inclined or more likely to have COPD. But there are slight problems with this registry. They had no smoking history. It was thought it might be higher in the MZs. The diagnosis of obstructive pulmonary disease also included asthma, with an increased risk of admission in younger age groups. So the data was a bit skewed, but it was showing us for the first time again there was an increased risk for hospitalization for obstructive lung disease in this population. So what we did some years ago is decide to do a new study. And our study was trying to get rid of this referral bias. So we decided to make an hypothesis that MZ siblings were at increased risk for COPD due to additional genetic and environmental factors, and that you'd find lower FEV1 levels in MZs compared to their siblings in families of MZ COPDs. So what that meant was if we had a person who was referred to us as an MZ with COPD, we'd look at their family members. We'd look at their MZ and their family members and compare them. And that would get rid of this referral bias because these people had not been referred to us with lung disease. They were merely the relatives of people who had been referred. So the nomenclature is important here. The people referred to us with COPD were probans, they were MZ probans, and we looked at them and we also looked at their and MZ siblings. So we used our national Alpha-1 detection program in Ireland to do that. So our national detection program is such that we test free of charge all people with COPD, all non-responsive asthmatics, all people with cryptogenic cirrhosis or liver disease, all first-degree relatives of people with alpha-1 deficiency. We also test people with paniculitis and vasculitis. So these are the people we test, and we have big numbers. So let's look at the numbers. So we've tested over 25,000 so far since 2004, and we have diagnosed about 5,000 MZs. At this moment in time, we have over 500 ZZs and over 500 SCs, and quite a number of people with rare mutations as well. But the group we're going to concentrate on now are the MZs, over 5,000. Now, we didn't look at all the 5,000. We looked at a very specific group, the siblings of those referred to us with COPD, and a small number of those. So again, let's talk about the population. People with MZ alpha-1 referred to us with COPD were called the probans. They are the affected individuals through which a family with a genetic disorder is ascertained. We enrolled their parents and siblings of these probans. We performed spirometry testing, questionnaire and phlebotomy on these individuals. We then looked for the presence or absence of COPD using qualitative measures and quantitative measures. And we investigated the impact of active and passive cigarette smoke on the risk for MZs as a genotype by environmental interaction. So again, the probans had to be greater than 30 years of age. We elected to look at only those with gold stage 2 to 4 COPD. They had to be confirmed MZs, no other lung disease, specifically no interstitial lung disease, and no other alpha-1 genotypes or phenotypes. And they had to be biological siblings. So here's the data. Let's look at the probans first. We identified 51 probans, age 64. And you can see a fairly standard group, quite a lot of pack year smoking there, you can see. And then we went to their relatives and their MZ relatives. 99 and 89 in each group. And again, fairly well matched. And you'll see same number of ever smokers throughout all the relative groups, more ever smokers in the pro-ban group, as you might expect, very few current smokers, and the pack years much more for the pro-bans than for the relatives, as you might expect, because a pro-ban comes to notice much more early than people detected by family screening. So let's look at the difference between these groups. So we saw an immediate difference, significant difference in FEV1 FVC ratio between the pro-bans and the other two groups, significant difference in FEV1% predicted between the pro-bans and the other two groups, and an FEF 2575. And that's not entirely unexpected. We expected to see a difference between the pro-bans and people detected by family screening. But then we started to look closer at the family screen group. And let's look at FEV1 over FVC. If you recall, I said that FEV1 FVC is the primary, endpoint for COPD. You have a decreased FEV1 FVC ratio. And we found that never smoking MMs had a similar FEV1 FVC ratio to MZs. There's no difference. But if you're a smoker, MZs had a significantly decreased FEV1 FVC ratio compared to MMs who smoked the same amount. So that was important.
Yeah.
We next looked at FEV1% predicted, and again we saw a similar result. In never smoking MMs and MZs, there's no difference. If you're a smoking MZ, it is significantly decreased FEV1% predicted. We next looked at FEF 2575, and if you recall, I said that this was a measure of flow at low lung volumes, your ability to blow out air at low lung volumes. And again, in never smokers, no significant difference in FEF 2575 between MMs and MZs, but in smokers, a very significant difference between MZs and MMs. So this data showed unequivocally that MZs who smoke had an increased risk for lung disease compared to MMs who smoked the same amount. The data wasn't as clear in non-smoking MZs. It did not seem to be an increased risk. Now then we looked at high versus low exposure. And high exposure was greater than 20 pack years. And again, low exposure, even with low exposure, the difference between MZs and MMs in FEV1 FVC ratio. High exposure, an even greater difference. So in other words, irrespective of your cigarette exposure, being an MZ put you at increased risk. If we look at FEV1% predicted, again we saw a difference between MZs and MMs in both low exposure and high exposure. And we saw the same for FEF 2575. So again, high exposure associated with very low FEF 2575, 41% predicted. So this data showed unequivocally that if you're an MZ and you smoke, you have an increased risk for COPD compared to an MM who smokes the same amount. And we looked at the odds ratios for that, and we looked at qualitative measures of COPD, and there's no doubt whatsoever that if you're a smoking MZ, you have an increased risk, definitively increased risk for COPD. If you're an MZ, full stop, you have an increased risk for COPD, but it's magnified when you smoke. And what is the increased risk? It's in fact a 10-fold increased risk for COPD compared to an MM who smokes the same amount. So smoking MZs have an increased risk for lung disease compared to non-smoking, compared to smoking MMs. So that was the data. And I think it's quite incontrovertible. That was the first family-based study, control study, and it showed that cigarette smoking in PIMZs is associated with a decreased FEV1 FVC ratio, a decreased FEV1% predicted, and a decreased FEF 2575, and unequivocally an increased risk for COPD. So smoking MZs are, when I say smoking, I mean ever smoking. It doesn't mean they're continuously smoking. Anyone who's ever smoked, MZs are at an increased risk. MZs who have never smoked do not seem to develop significant lung disease. That was what we found at that time. Now let's put a caveat to all that. The caveat is that these are just one point in time. We looked at a person's lung function at a certain point in time. And we thought we'd have to do a bit more in-depth studies than that. But the data was quite strong. An MZ who smokes, or whoever smoked, has an increased risk for COPD compared to an MM who smokes the same amount. But it's not just MZ and smoking that's the problem. What happens if you're an MZ and you smoke and you're exposed to certain vapors, gases, dusts, and fumes? Well, the data in that is quite incontrovertible as well. So this data shows that if you are an MZ and you have smoked in the past and you're exposed to high level of vapor, gases, dusts, and fumes, you have a significantly decreased FEF 2575 compared to an MM who's at the same exposures. So again, it's all cumulative. You're an MZ and you've smoked, even for a relatively short time, you have an increased risk for lung disease. You're an MZ and you've smoked and you're exposed to dust, gas, and fumes, you have an increased risk for lung disease. Now, we have often talked about alpha-1 antitrypsin deficiency lung disease and the liver disease almost as two different types of disease. In other words, the liver disease, we have always felt, was due to polymerization of the Z alpha-1 in the liver, causing liver inflammation, and failure of that alpha-1 to get out of the liver in sufficient quantities to protect the lung. That was the hypothesis. And the belief was that in the liver you had a gain of function, a gain of toxic function. In the lungs you had a loss of function. So in other words, the Z alpha-1 polymerizes in the liver, causes inflammation in the liver, and fails to get out in sufficient quantities to protect the lung. So therefore, the treatment for the lung disease would be to give intravenous alpha-1 antitrypsin or some other augmentation therapy to increase the level of alpha-1 in your lung. We're not so sure it's as simple as that. Let's go back to this protective threshold. If you think about this, again, in the simplistic form, we thought the ZZ form has a low level of alpha-1 in blood, a low level of alpha-1 in the lung, and therefore increasing the levels of alpha-1 in your lung will slow down or decrease progression of lung disease. And let's be honest, it does. In ZZs, plasma purified alpha-1 antitrypsin given intravenously once a week slows down progression of emphysema and increases survival. But is that the only story? Is that the only problem that people have with the lung disease in alpha-1? Is it just purely a levels thing? In other words, if you increase your levels of alpha-1, is that sufficient? And the data we have from MZs would suggest it's not. Because if you remember, MZs who've ever smoked, have an increased risk for lung disease. So it's not just a level thing then. It can't be just a level. It's a degree of inflammation which the levels of alpha-1 have to combat. And one way of looking at that, if you remember, we said in the liver, the alpha-1 antitrypsin, the Z alpha-1 antitrypsin, polymerizes in the liver and causes liver damage. Do polymers occur in the lung? Well, we've actually showed that they do, actually. And if you measure polymers, you can measure them in the lung or you can measure them in blood. And again, if you go back to this graph here, the risk of lung disease increases as your levels decrease. But the risk of lung disease also increases as your levels of polymer increase. So you can measure the levels of polymer in the bloodstream, and that can also reflect what's happening in the liver, but we also know it reflects what's happening in the lung. So if you have high levels of polymer in the blood, you probably also have it in the lung as well. So how do you differentiate between the two? What's the most important one? Is it the levels of alpha-1 you have, or is it the degree of polymer? Now, I think both are important. I think the levels are probably more important, but they're both important. But how do you tease out the difference? Now, there's one way you can do it, and that's to look at people with the SS form of alpha-1 and people with the MZ form of alpha-1. So let's think about that. The SS form of alpha-1 has the same level of alpha-1 antitrypsin in blood and in the lung as the MZ form. But if you remember, the polymer level in SS is much lower than in MZs. So this is a way to tease out the difference. Because if it's just a level matter, then SSs should have the same clinical trajectory as MZs. But they don't. So here's data we just recently got out. This is a study that was sponsored by the Alpha1 Foundation in the US. It's not finished yet, but it's interesting data. We've looked at Alpha1 levels at diagnosis, and then we followed up people over a long period of time. And I just show you some of the early data on this. The little purple dots are MZ ever smokers. The orange dots are MZ never smokers. The green are SS ever smokers, and the black are SS never smokers. You can see straight away, the majority of people with low lung function are MZ ever smokers and some MZ never smokers. So again, it seems to give us further data that MZs do worse than others. But not only that, it's not necessarily just a levels matter. It may also be a factor of the amount of inflammation you have in your lung, which we may be able to measure looking at polymers. So that's a short summary of the work we've done on MZs so far. But I want to also remind you about MZs, that the MZ form of alpha-1 may interact with other genes. And I'll give you a short case resume of a few patients of ours who made us think more about this matter. An individual came into us, he's an MZ individual, he came into us age 35, or age 30, sorry, never smoking MZ with very severe early onset emphysema. Very severe emphysema. So bad, in fact, that he needed lung transplantation. His brother came in, MZ never smoker, very severe early onset emphysema. Now that's very unusual. So if you ever see a person, an MZ individual with never smoker, and he's young, and he's severe emphysema, it's not just simply MZ. So bear that in mind. We went to his father. His father was an MZ ex-smoker, had mild COPD. And this is the young man, what we call the proband case. You can see here quite significant emphysema on his right-hand side, pre-transplant. And just before a transplant, quite a lot of emphysema there. And we looked at the family members, because this is the important thing about doing family studies. That's why it's important that you always look in the context of the family. So you can see here an MZ, two MZs in the family, both required lung transplantation in their 30s. Another son, unfortunately, had spina bifida, and he died early. The father, MZ, mild COPD. But the really interesting thing was the mother. And this is the mother's lung function here. And you can see significantly decreased FEV1, significantly decreased FEV1 FVC, significantly decreased FEF 2575, and decreased DLCO. Classic emphysema in an MM who never smoked.
Wow.
And what that means, when we looked at the sons, we did what we call whole genome sequencing on the mother, and we found that she had certain areas of genetic mutation that she had passed on to the sons. And the sons, in the setting of MZ, got a very severe form of emphysema from that. So again, to put it in context, if you have an MZ individual and they present very early with severe emphysema and they've never smoked, think about other confounding factors that can add into that. I'll briefly discuss the cirrhosis or liver risk. You've probably gone through this before and probably later on. This is good work from Pavel Strad in Aachen. And again, he showed that MZs have an increased risk for liver disease, but you'll cover that elsewhere. So lung disease and liver disease. And I'm going to finish with one other one that you may not be aware of. That's not just lung and liver disease. We looked at 246 people with rheumatoid arthritis. We found no differences in the prevalence of alpha-1 in the general population. So in other words, the number of people in the rheumatoid population hadn't got an increased number of alpha-1 patients there. But those patients in the rheumatoid arthritis population who were MZs had more severe rheumatoid arthritis. They had higher levels of rheumatoid arthritis antibodies And this is associated with a much more severe prognosis than people without the MZ form. So, in summary, what we are saying tonight is that people with the MZ form of alpha-1 who have ever smoked have an increased risk for lung disease. We think that those people who have not smoked may have no markedly significantly increased risk for lung disease, but there may be a signal there that they have a risk given certain exposures. We know that MZs who smoke and are exposed to dust, gases, and fumes have an increased risk for decreased lung function. We know that MZ form of alpha-1 can interact with other genes to give you a very severe form of emphysema. We know that alpha-1 can be associated with liver disease, even in its MZ form. And finally, MZ alpha-1 in the setting of what are loosely regarded as autoimmune disorders, such as rheumatoid arthritis, may actually act to give a more severe phenotype of that condition than those without MZ alpha-1 antitrypsin deficiency. I'll end there and be happy to take any questions.
Well, we do the questions at the end, if you don't mind, Gerry.
I'll have to leave, unfortunately. If Frans
okay. Okay. Then, if there are questions, Nienke or Fiona, did you have questions for?
Yes, I have quite a few questions. Fiona, have you picked them up? Okay, I have one question here. So how does growing up with secondhand smoke exposure by both parents affecting the COPD risk?
With the, sorry, secondhand. Wait, so we haven't got a good.
How does growing up with secondhand smoke exposure by both parents affect the COPD risk?
Yeah, we don't have a good handle on that because it's very difficult to accurately measure the degree of secondhand exposure. So we don't have a good. We do know that people who grow up in a family of smokers are more likely to be smokers themselves. We've shown that in our alpha-1 population. So we know that people who grow up in a family where either of the parents smoke are more likely to be smokers. And not only are they likely to be smokers, they are likely to be early smokers. And we think early smoking is bad. To put this in context, the majority of Irish people who smoke start at age 15 and stop at age 35. And they still have significant emphysema if they're ZZ alpha-1s.
Correct.
Thank you. And I have a question. What if the mother smoked during early pregnancies and the kid is MZ?
Is smoking in early pregnancy?
Yes.
We have no data on that.
Oh.
All right. And then someone's asking what a polymer is.
Yeah, I will handle that a little bit later on in the.
All right.
Yeah.
And then there might be another. I'm afraid we can't have all the questions, but I will definitely save them. And someone else, is there a connection with to other autoimmune issues or fibromyalgia?
Yeah, there's not a, with regards to fibromyalgia, probably not, but there is a relationship with vasculitides. So in other words, we have good data that people with specific types of vasculitis have an increased risk if they're alpha-1 deficient. So for example, there's a condition called granulomatous angiitis, which can be quite severe. And this is increased risk in people with the MZ form of alpha-1 and a very severe outcome in ZZ alpha-1. And the reason for that is alpha-1 has a very potent anti-inflammatory and can decrease the inflammation which is caused by this condition. So there is a definite link between vasculitis and alpha-1 antitrypsin deficiency and a skin condition called panniculitis. Panniculitis is more common in ZZ individuals, but it's also found in MZs. And even in MZs, the treatment of choice in very severe panniculitis is infusion of plasma purified alpha-1 antitrypsin.
Correct. Yeah.
Yes, because there is a question by Erin Goody, is it, for you, Gerry? And she says her sister is an MZ and has out of control panniculitis, and her current doctor is having her take dapsone to help, as they will try to get her open wounds to heal.
Yeah.
It's reduced her neutrophils and has stopped the wounds from getting worse, but they're not getting any better either. She feels she would not qualify for gene augmentation because her current alpha-1 antitrypsin levels are in the normal range. So she wonders, is there any other treatments that they
Yeah,
explore?
it's a very interesting question, actually. So we have quite a large Alpha-1 clinic. We've identified 3 people with significant panniculitis and 2 others with mild panniculitis. And if you, we've actually written a paper on this, which looks at how panniculitis can actually be a life-threatening condition. So in other words, people can die from panniculitis. The standard therapy in the dermatology books is Dapsone. But in severe panniculitis, Dapsone won't deliver an appropriate therapy. And if you're severe panniculitis, the best therapy is intravenous alpha-1 antitrypsin. Now, the dilemma for your patient is they'll find it hard to get intravenous alpha-1 antitrypsin for a condition when their alpha-1 antitrypsin levels are within the so-called normal range.
That's correct.
But there is I should say there is a parallel for that in COVID inflammation. So if you look at COVID inflammation, when COVID causes severe lung disease, we have shown that the alpha-1 antitrypsin levels can go up quite highly, but they're still not sufficient for the inflammation in the lung. And we had actually given intravenous alpha-1 to COVID patients with some good results. So I think, although it's standard thinking that panniculitis cannot be treated with intravenous alpha-1 in the setting of MZ levels, if she gets severe panniculitis, the first treatment course she should go on should be intravenous alpha-1.
Okay, thank you so much for your answer. That's very interesting.
I think that we have to move on now with an eye on the time. Yeah. Well, thank you very much, Gerry. It was very, very helpful and very interesting. And I have some questions as well, but that will come later.
Thank you all. Bye now.
And thank you. If you can stop sharing.